Hello, everyone. Good afternoon, good morning. Thank you so much for joining us on today's session of the Solventum Afternoon Coffee. My name is Jordan Fallon. I will be your host and moderator of today's session. I am joined today by two of my colleagues, Rebecca Caux-Harry and Lane Lewis. Before I pass it over to my colleagues to dive into today's content, I just want to go over a few housekeeping items. If there are any questions during the session, please feel free to put them in the Q&A portion of your toolbar at the top of the screen or in the chat session. We have allotted time for Q&A at the end of the session. Also, we do have a poll question towards the beginning of our PowerPoint presentation that we would love your participation in when that comes around. And lastly, we will be recording the session and providing the recording and a PDF copy of the slides. So you can look forward to that following the session today. So with that, thank you all so much again for joining us for today's session of the Solventum Afternoon Coffee. And I'm going to go ahead and pass it over to my colleague, Rebecca.
Thanks so much, Jordan. I just want to run through a couple of slides to introduce you or remind you, if that's the case, of who Solventum is. Earlier this year, April 1st to be exact, Solventum spun off from 3M and to form its own company, and Health Information Systems was part of that spin. That's who we are. So we have 40 years of experience leading the healthcare industry and supporting healthcare with a variety of tools. So you may be hearing about brand new companies coming to the market with artificial intelligence built in to help support that workflow. Solventum, a new company, but the same leading technology, has been around for more than 40 years, offering medical coding experience. You can see on this slide all of the numbers of what we've been doing for the last 40 years in terms of coding, including 40 plus years of contract with CMS and other government agencies, a partnership with Amazon Web Services, and internally 150 plus clinical and content experts. So this allows us to support our customers extremely well with leading technology. So Solventum at a glance, 70 plus years of innovation, as I had mentioned, 40 of which we've been in the coding space, 7,300 patents issued, over 22,000 employees, putting us in a position of market leadership and as a trusted, recognized brand. In terms of our ambulatory solutions, our focus is on simplifying the lives of physicians, allowing them more time to care for their customers. Physicians didn't get into practicing medicine in order to code those services, document those services. And so our solutions will support those physicians, allowing them to focus on providing care, whether it's capturing the language in a native scenario, supporting the documentation integrity with a variety of services, providing coding support also with a variety of options, and the result being quality outcomes, providing ability to do population analytics. You can see a number of different products listed on this slide that my colleague Lane will talk about a little bit later in the webinar, but this is really important to Solventum. And you can see on the bottom of the slide why this is important. It allows our customers to enjoy a 30% increase in their productivity, 25% increase in the HCC RAF scores, 25% increase in revenue, as well as 3.6% increase in gross savings. So Jordan had mentioned earlier that we have a polling question for you. What we'd like to know is, what are your top 3 challenges in your workspace currently? And the poll has been launched. We'll give you about 60 seconds to respond. How much more time do we have, Jordan?
We'll give about another 15 seconds.
Thank you.
If you haven't had a moment to respond to the poll question, we'd love your participation in that.
I see somebody posted her response in the chat.
Yeah, that's totally fine too. That's great.
Modifier coverage, coding compliance. Yep, yep. Coding. Thank you.
All right, I'm gonna go ahead and close the chat or close the poll. It looks like our top 3 would be denial reduction, accurate CDI capture, and coding compliance. It's kind of a across the board. There's some responses to all of them.
Okay, great.
Thank you so much for that participation.
Thanks, everyone. So we're going to talk about the results of physician coding. Most of the smaller practices have a pretty common workflow. And these are the things that I see as I go in to talk to our customers. So one of my questions, is that coding supported? There's a limited number of E&M CPT codes, and that's normally what physicians are involved in mostly when they're asked to submit coding for their services, but thousands and thousands of ICDs, and those coding guidelines for those ICDs are complex and varied. All of the services captured. Are the physicians performing services above and beyond that E&M service? And do they know when it's appropriate to add an additional CPT code, therefore additional revenue capture, and what the documentation requirements are for those additional CPTs? Do the providers know when it's appropriate to use modifiers? Someone in the chat had mentioned that was her primary concern. Do the physicians know? There are often times when I've heard billers addressing denials, oh, just put a 59 or a 25 modifier on it, it'll get paid. Well, yeah, it might get paid, but there are specific requirements to using those high-risk modifiers. Do the people appending those modifiers know what they are? Are those people putting you at higher risk by using those modifiers? So are they being applied appropriately? And in terms of the patient's condition, is the specificity being accurately captured? Often the physicians in their workflow, in their EMR, they'll just select a single ICD, but the patient is usually far more complex. Often the physicians will select the previously reported ICDs without validating the correctness or supporting documentation for those ICDs. Also, is the patient's complete history being accurately captured based on the language within that physician's notes? Are the physicians capturing those chronic conditions that they're monitoring, assessing, treating in that particular scenario? The specificity of the ICD-10 codes is quite deep, and being able to capture those fully is generally not high on a physician's list of things to do today. They want to treat their patients and move on. Capturing that specificity is something that's pretty low on their list. So we talk about total cost to collect as a metric as we evaluate the physician practices. So how do we calculate that? So the total cost to collect takes the total cost of collecting payments and dividing that by the total amount of payments collected. And that cost will include the salary and benefits of the staff, any software and overhead related to collecting payments, and possibly even some physician time used to assign codes, to address denials, to address queries based on codes that they've supplied. So that might be a soft number, but it's also part of that total cost. The industry standard benchmark for cost to collect is around 2 to 4% of net patient revenue. And ways to impact or reduce, to improve the total cost to collect would be to reduce denials and claims rework. The MGMA estimates that each denial costs at least $25 to address. In speaking with practices previously, I've had practices actually laugh in my face when I mentioned that $25 benchmark, saying, "Oh, that's a total underestimation. It costs us way more to address those denials and get them reworked." So reducing denials reduces that cost to collect significantly. I think that's the number one thing that would be the goal. Streamlining the workflow from documentation to code assignment to submission to payment. The shortest line equals the lowest cost to get the payment for that service that's been provided. A lot of our customers will implement technology solutions to help them with that, with edit alerts, with automation, anything that we can do. And Lane will speak to those here shortly. Monitoring key performance indicators such as accounts receivable, denial rates, and collection rates. Also improving your patient communication. This would include, "Hi patient, I see you have this particular insurance, you have a copay or a co-insurance today." Getting that communication up front so that they're aware, so that you don't have to touch that particular account repeatedly in order to get appropriate payment, will help reduce or positively impact that total cost to collect. In terms of workflow, what we're seeing most frequently is that physicians and other care providers are usually required to select their procedure codes or CPTs and diagnosis codes as part of their workflow within the EMR, with little to no validation of those codes and the documentation that's required to support those codes. Codes will then move through a claim scrubber or a work list. If they hit an edit, edits will then populate a work list within the EMR, and that's usually the responsibility of the practice group to establish those work lists, maintain them, update them based on new denials, based on new edits, new code sets that come out, and that can be kind of a cumbersome process to maintain. The edits will then be addressed by a biller or a coder, hopefully a coder that knows how to appropriately address that. Claims are then submitted to the payer. The claim is either paid, which would be awesome, we're done, or it's denied. And then if denied, the claim is either corrected and resubmitted. This is that $25 of looking at the documentation, looking at the codes, validating that it's correct. If it's not, correcting it, resubmitting it, determining that it's too low of reimbursement to refile, and then writing it off, or appealing that denial. All of that is a very common workflow. That back-end workflow is such a large part of the cost to collect. So streamlining that is the ideal process. So the results: providers have an uneven education regarding coding convention. The codes may or may not be supported, resulting in a compliance concern. I think somebody had mentioned compliance was her primary concern. We might have missed procedures. We might have incorrect coding going in due to lack of understanding that results in unnecessary write-offs. Because the coding rules change, non-coders really do have a difficult time keeping up with all of those changes. And then the small practices are usually priced out of the advanced technology that would automate a variety of these issues. So coding related denial issues. So one of the biggest ones that I see is coding for consults. CMS stopped paying for consults back in 2010. However, those codes still exist, and some commercial payers pay them, some don't. It's important to know which payers accept those. Medical necessity edits. Physicians don't normally keep track of what's payable. They know what's medically appropriate in terms of their testing, and they're going to order that testing, whether it's paid or not. It's our job in the office to ensure that those services are paid. And then bundling edits. CMS updates those policies twice a year on services that can and cannot be billed together. And it's our job as coders to know those policies and know when it's appropriate to use modifiers to bypass those edits to get appropriate payment for those services provided. And then the coding convention. The coding rules are voluminous. There are a wide variety of areas where we can get denials based on ICD and CPT coding convention that physicians have a really difficult time keeping up with because it's not their primary concern. As a coding technology, that is our primary concern, to present those to coders so that they can address those issues and get those services paid. So one of the ways that we combat all of these problems as a result of the common workflow is to do audits. So where do you start? So audits, they're a proactive way to capture some of the issues, to know where you are in the compliance realm in terms of what you need to fix and what's working well. Most groups will support either prospective or retrospective audits. Each has its own drawbacks. Prospective audits means you're holding charges, increasing your AR days in order to validate that the codes are supported. Retrospective audits, should you find an issue, results in submitting a corrected claim that causes workflow issues downstream as well. One area to start would be to look at new versus established patients with additional services, ancillary services. A lot of physicians don't really know those guidelines for new versus established patients. One of the things that I always target is modifier usage. Those high-risk modifiers, I always want to audit based on those. And then also target testing, some of those high complex, high dollar testing that we do that has a high denial rate. Providing education and a re-audit. Often, this is personal experience, external subject matter expert voices carry a lot more weight than the internal expert voices, even when delivering the same message. So oftentimes outsourcing auditing gets better buy-in from the physicians and the providers in terms of response and capturing that data. Some physicians respond to education, some don't. You need to re-audit to find out where you've been successful and where you've not in terms of that auditing and education. And then most importantly, you need to develop a compliance plan, communicate that to compliance plan and stick with it. So do you have one? The DOJ has outlined 7 elements, and I'm just going to build this out, of what a good compliance plan is. You need to have compliance leadership. That's going to be someone that's at the highest level of your organization that is named the compliance officer, and give them some teeth. Do a risk assessment, that initial audit. Where are you now? Where do you need to get to? Written policies and procedures with guidance so that the company can follow those policies. Training and communication. Send this compliance plan out, have it in a common location, do periodic training and certification on the compliance plan so that you can ensure everyone is aware that you have a compliance plan and that you need to follow it. There also needs to be a confidential reporting structure. If there's a fear of a report of a compliance concern and retaliation, then your compliance plan is going to fail. It needs to be confidential. You need to enforce the standards of your compliance plan, and you need to respond to detected offenses and develop corrective action. So all of these things are important in terms of having that compliance plan. In fact, having a compliance plan and not following it is, in fact, more risky than not. So at this point, I'm going to turn the presentation over to my colleague Lane to talk about those different offerings.
Great. Thank you, Rebecca. Yeah, I want to talk just a little bit about what we can do as Solventum to help. Our mission as an organization is really about enabling better, smarter, safer healthcare. And as a division with health information systems, we're really focused in three main areas, as Rebecca touched on a little bit earlier. First of all, that creating more time to care for physicians. And you'll see that's the first area we can really help with is documentation capture. So when the physician is treating a patient, how can we capture that appropriate documentation? We can do that through tools like speech recognition, where they can dictate the treatment that is provided and the conditions to be able to capture that to code that record appropriately. We've also created new technology ambient solutions that are really exciting because of the amount of time that they can save in creating that time to care for physicians. And that utilizes generative AI to capture that patient-physician interaction as a natural byproduct of that treatment. The second thing that we do is look at eliminating revenue cycle waste. And we can do that in several different ways. We can do that through our documentation integrity, looking at making sure that we're capturing hierarchical conditions like HCCs. We can also do that through our consulting services. Rebecca mentioned tools like audits. We can do that through our consulting, where we can do a focus audit to make sure that appropriate coding is being applied. Physicians that may need specific education, whether it's on HCCs or appropriate use of modifiers, we can really pinpoint areas of need by looking at a review based on a specific audit. Then we can also eliminate that revenue cycle waste by our coding tools. And again, Rebecca mentioned our 40 years of experience in medical coding. And we do that in several different ways. One, we do have facility coding tools, our coding and reimbursement system. But in the independent physician practice space, more frequently used are physicians coding and reimbursement system. This is more than just a code lookup, but it actually creates those logic pathways to drive compliant coding, both in the ICD-10 as well as the CPT coding. And that would provide all those specific edits to the physician coding, the NCCI edits, the medical necessity edits, and has all of the references contained within the tool for compliant and accurate coding. We go beyond that manual system as well of a coding and reimbursement system in looking at computer-assisted coding. That's typically offered more in the facility coding space, but we do that for physician coding as well. And that would be with the computer-assisted coding. And now, again, based on our 40 years of experience, being able to leverage that to moving forward with new technology with autonomous coding. And we like to kind of refer to that as automate the easy. how can we help coders and others operate at the top of their credential and automate the things that are easy and do that in an accurate manner. So we're really excited about the potential and where we are heading with autonomous coding. The other thing that we can help, especially in the independent physician practice space, is with outsourced coding services. And we can do that both for inpatient facility, outpatient facility, and professional charges. We can do that as needed. So, you know, if you have a coder that is out on maternity, we can fill in, or we can take over the entire coding for a department. We have both onshore and offshore options available, although I always like to mention that even on our offshore, which is quite a bit less expensive, we do have a dedicated domestic account manager so that you're working with a single domestic contact to be able to manage your account and make sure that you have the accuracy and the quality coding that is needed. The last area of our commitment in our division, the Health Information Systems, is driving value-based care. And we do that in several different ways. Some examples of that is in some of our groupers. So we have an AMPPC grouper, which is an ambulatory potentially preventable condition grouper. And essentially what that is a classification of outpatient quality. Specifically focusing on complications after an ambulatory procedure. So how can we improve the quality within the outpatient setting? EAPGs is more of a classification of outpatient payment. So how can you show the impact of capturing all of that appropriate documentation and the impact that that has on the acuity of the patients? And then we have clinical risk groupers as well that can categorize patients' risk based on outpatient conditions that they see. So that's kind of the areas that we can help as an organization in this space. But at this point, we have a few minutes. I want to open it up for any questions that we might have or closing comments as well.
Thanks so much, Lane and Rebecca. I'm going to go ahead and launch our last poll question. It's really an action item. How can we help you best moving forward after this afternoon coffee session? So please take a moment and check that out, see how we can help you following the session. Let's see if there are any questions. If there are any questions, please go ahead and put them in the chat or Q&A portion. I don't see any at this time, Lane or Rebecca. So if you have any closing thoughts that you kind of would want to leave the group, we can kind of do that and then kind of give everyone back some time.
No, we appreciate your time today. Go ahead, Rebecca.
I was just going to reiterate that this session was recorded and we will be sending out a PDF version of the slide deck for your review.
Thank you so much, Rebecca. We'll stick around for the one last minute of the session, but really do appreciate everyone jumping on and giving us 30 minutes of their time. Hope this was valuable for you. Please go ahead and answer that last poll question of how we can help you if you believe that's applicable for you. Thank you so much again. We really appreciate your time, and we hope to see you at the next afternoon coffee. Lane, Rebecca, Ron, thank you so much for your time and your help.
Thank you. Bye.
Thank you. Have a great day.
Thanks, everyone.
Bye.
Have a great day.